Okay. So today I'm going to discuss about the Parkinson disease. Before discussing the Parkinson disease, before discussing the Parkinson disease, first we have to discuss about the basal ganglia. So what is the basal ganglia? Can anybody tell? Basal ganglia. So basal ganglia is basically subcortical structures. They are subcortical structures that located deeply within the white matter of the brain. So typically basal ganglia is a nuclei, five pair of nuclei. So that includes caudate, putamen, globus pallidus, substantia nigra, and subthalamic nuclei. So these five nuclei, subcortical structures, make the basal ganglia, right? So basal ganglia involved in the movement. They control the movement, right? Okay. So for the basal ganglia point of view, for the movement purpose, we have two pathways, direct pathway and indirect pathway. We will discuss these pathway in detail, right? So direct and indirect pathway. Okay. So what is a striatum? Can anybody tell what is a striatum? So striatum is basically the combination of putamen and caudate nuclei. So this putamen and caudate, or this caudate and this putamen make striatum, right? And what is a lentiform nucleus? So lentiform nucleus is basically the putamen plus globus pallidus. So do two terminologies, striatum and the lentiform. I hope all of you know about that. What is a striatum? Can anybody repeat? What is a striatum? What is a striatum? Rob, can you repeat this, please?
Sorry, I had stepped away to open my door, so I wasn't.
Okay. I
Yeah.
discussed two terminologies, striatum, right? And lentiform nucleus. Striatum nucleus and lentiform. Striatum is consist of putamen.
Lentiform composed of putamen and globus pallidus. You say that's from lentiform nucleus.
Yes, you are absolutely right. Putamen and caudate. While the lentiform nucleus is consist of, you are absolutely right, putamen,
And globus pallidus.
globus pallidus, right? Okay. So there's the two pathways for the basal ganglia point of view, direct and indirect pathway, right? So direct pathway lead to facilitate movement. Direct pathway facilitate movement, right?
Okay.
And indirect pathway inhibit movement. Okay. So this is striatum. This one is a striatum, right? And this is substantia nigra, and this is a motor cortex. Motor cortex input on striatum. This motor cortex input on striatum release glutamate. It releases glutamate, right? So this glutamate stimulates this striatum to release GABA. So GABA is released from striatum. So GABA is released from striatum and acts on globus pallidus interna, right? So GABA is inhibitory or excitatory neurotransmitter. It may be excitatory and may be inhibitory, but we generally consider it inhibitory, right? So if this GABA that is released from striatum is act directly on globus pallidus interna, it will inhibit the globus pallidus interna, right? So it will inhibit the globus pallidus interna to release GABA. And in this way, it will activate the thalamus. And in this way, thalamus gives signal to cortex to facilitate movement. So this is a direct pathway. The motor cortex directly go to the globus pallidus. So motor cortex, striatum, globus pallidus interna, thalamus, and motor. So this is direct pathway, right? Now I'm going to discuss about indirect pathway. So in indirect pathway, so what will happen? Again, the input comes from the motor cortex, and then on motor cortex, synapse on the striatum, and this release the input from the motor cortex release glutamate, right? So this glutamate causes release of GABA from the striatum, and it will synapse on the globus pallidus externa, right? So indirect pathway, cortical input stimulate the GABA release from the striatum, which inhibit the GABA release, from the globus pallidus externa, right? And this globus pallidus externa synapse to the subthalamic nuclei, right? So it will synapse with the subthalamic nuclei, and it will disinhibit this subthalamic nuclei, and this subthalamic nuclei will synapse with the globus pallidus interna, right? So this globus pallidus interna, now it is a stimulatory. So this pathway that involve the globus pallidus externa subthalamic nuclei, it known as a indirect pathway. So indirect pathway inhibit movement, right? While direct pathway facilitate movement. Okay. So what happened in the Parkinson disease? Can anybody tell what is happen in Parkinson disease? Rock, can you hear me?
Substantia nigra.
Yes, there is a damage in the substantia nigra, dopaminergic neuron damage.
Yeah.
So there is a decrease in dopamine due to damage in substantia nigra, right? Okay. Now I'm moving towards this is the high yield, the most high yield thing that you found on the UWorld and NBME. Okay. Nigrostriatal pathway. So this nigrostriatal pathway is basically affected by Parkinson disease, and it is a target for other any drug Can anybody name the drug? Which drug? Antipsychotic. So Parkinson, an antipsychotic. So the nigrostriatal pathway, right? So this nigrostriatal pathway that start in the substantia nigra that is present in the midbrain and it end at the striatum. So that's why it is called nigrostriatal pathway, right? So there is high yield question. They give you the history of the schizophrenia, right? So schizophrenia is treated by antipsychotic, right? Antipsychotics are mainly dopamine antagonists, right? So, so one of the side effects of the antipsychotics is increased prolactin. When his prolactin level is increased, it lead to galactorrhea, right? So in the clinical minute, they show you the history of the schizophrenia, plus taking the antipsychotic and give you the increased prolactin. So which of the following pathway, which of the following pathway is affected by these drugs that the patient has taken? Can anybody tell? That is a high yield concept.
Okay, nigrostriatal pathway affected in patient with Parkinson disease. And you said that we will give you a case of schizophrenia, which is treated by dopamine antagonist, and this will really, result in increase in prolactin level and galactorrhea.
Okay. So they ask about which effect of this drug is responsible for the increased prolactin level. So they're asking about why the prolactin is increased. So which pathway is affected?
Nigrostriatal pathway.
No, you are wrong. That is a tuberoinfundibular pathway, right? So
Okay.
tuberoinfundibular pathway is basically the pathway that starts the the hypothalamus to the pituitary. So this pathway, right? So tuberoinfundibular pathway is culprit for the increased prolactin level. The patient who taking antipsychotic. Although the main thing, the nigrostriatal pathway is affected in Parkinson disease, right?
Okay.
And antipsychotic also affect this pathway. But when you heard about the prolactin, then the answer is tuberoinfundibular pathway, right?
Yeah.
Okay, I modified this question again. So schizophrenia plus antipsychotic. Schizophrenia plus antipsychotic. Okay, so the patient negative symptoms does not improve because this antipsychotic has limited effect on this mesocortical pathway. So this mesocortical pathway is responsible for the negative symptoms in schizophrenia. So the mesocortical pathway is responsible for the negative symptoms in schizophrenia, right?
Okay.
And which pathway is responsible for the positive symptoms in the schizophrenia? Which pathway is responsible for the positive symptoms in the schizophrenia?
Mbbs.
mesolimbic. So these four pathways, these are dopaminergic pathways that are super high yield. So if you think about the negative symptom, mesocortical pathway. If it is a positive symptom, mesolimbic pathway. If you think about there is a movement problem, then it is a nigrostriatal pathway. And if the prolactin issue, then it will be fibroinfundibular pathway, right? So you have to know
Yeah.
these pathways and their effect. Okay. So USMLE love to ask the sections. So brain sections, brain stem sections, right? Okay. So sometimes they want to know about on these things on this CTs. So in this picture, C represents caudate, right? L represents lentiform nucleus. Lentiform nucleus is combination of putamen and putamen.
Lentiform and globus, putamen and globus pallidus.
Okay. So striatum is
Putamen and caudate.
okay. So this is a thalamus. This one. So you have to know. I miss one picture. The midbrain section are super high yield. Midbrain section of the brainstem is a super high yield. I forget to add this picture in this slide. Uh, right? Okay. Okay. So now I'm going to discuss about the treatment of the Parkinson disease. Before discussing the treatment of the Parkinson disease, can anybody tell me the symptom of the Parkinson? What are the symptoms of the Parkinson?
They have abnormal movement that
So,
have
no, the mnemonic of the Parkinson is simple. Trap, right? T for tremor.
yeah,
A for rigidity.
rigidity.
A for akinesia. And P for postural instability. Right? So tremors are in Parkinson are resting. Right? So resting tremors. So rigidity are cogwheel, cogwheel or lead pipe rigidity. Akinesia or bradykinesia. So the patient has a problem with initiating the movement, right? So patient also has sometimes present with the micrographia. Micrographia is small handwriting, right? Okay, so these are the some high yield symptoms of the Parkinson disease, right? And the culprit is sub damage in substantia nigra, right? So substantia nigra dopaminergic contain neurons are damaged, right? Okay. So now I'm going to discuss about the some high yield pharmacology of the Parkinson disease. Okay. So I'm dividing the drugs into many types. First is dopamine agonist. So dopamine agonist drug that directly act on dopamine receptors, right? So they are divided into the two types: non-ergot and ergot derivative. So preferred drugs are non-ergot, and the example is pramipexole. Examples are pramipexole, while ergot derivative dopamine agonist example is bromocriptine. Okay, the side effect of the non-ergot like pramipexole are high yield. So the side effect of this drug is gambling, postural instability, hallucination, confusion, and edema, right? So these are dopamine agonists. We divide the dopamine agonist into two types: non-ergot and ergot derivatives, right? Okay. Now I'm going to discuss about the drug that lead to the increased dopamine availability. That is amantadine. What amantadine do? It cause increased release of dopamine and decrease the reuptake of the dopamine. So increase dopamine available, and it will relieve the symptom of the Parkinson, right? Okay. So now I'm going to discuss of the some most high yield drugs, L-dopa and carbidopa, right? So L-dopa that cross the blood-brain barrier that convert into the dopamine by enzyme dopamine decarboxylase. So we give a drug that is called carbidopa with L-dopa. So why we give carbidopa? Because this carbidopa is basically dopa decarboxylase inhibitor, and this carbidopa does not cross the blood-brain barrier, right? So it will prevent the peripheral side effect of the dopamine, right? We also use another drugs that are formed inhibitor that metabolize this L-dopa into 3-OMD, right? These drugs are anti-capone, tolcapone, right? So now I'm going to discuss about some other drugs that prevent the breakdown of the dopamine, right? So monoamine oxidase type 2B inhibitor. So these drugs basically inhibit an enzyme that is a monoamine oxidase B and prevent the breakdown of the dopamine into the DOPAC, right? Another drug that is a talpopone is also inhibit an enzyme COMT, catechol methyltransferase, and this enzyme convert the dopamine into the 3-MT, right? So in this way, we will prevent the breakdown of the dopamine in the presynaptic terminal in the CNS, right? So can anybody tell the what are the side effects of the levodopa? The side effects of the levodopa are hallucination,
Nausea.
yes, hallucination, Postural hypotension. These are high yield side effects. One more is on-off phenomena. On-off phenomena. Right? So what is on-off phenomena? It is basically a phenomena in which sometimes there is improved mobility and sometimes there is a impaired mobility in a certain period because the patient doesn't respond to this drug. This is called on-off phenomena. And when the disease is progressing, then this phenomena occur frequently. On-off phenomena. Right? Rock, does it make some sense? On-off phenomena.
Yes.
When the Parkinson disease is progressing, okay, so this is again a simple classification of the anti-Parkinson drug. So can anybody dopamine agonist divided into two types?
Good
Rock,
and ergot derivatives.
non-ergot and ergot. So non-ergot are preferred. Increased dopamine availability. The famous drug is amantadine. Right? Increased dopamine availability are carbidopa. Carbidopa is inhibit which enzyme?
Dopa carboxylase.
Entacapone. They inhibit which enzyme? They inhibit which enzyme?
Dopa decarboxylase.
Entacapone and talcopane. They inhibit COMT enzyme. They are COMT inhibitors. And this is dopa decarboxylase inhibitor. Right? Prevent dopamine breakdown. So they are monoamine oxidase B inhibitor. Right? And talcopone. Again, talcopone is COMT inhibitor. Right? Okay. So the tremor is basically due to increased cholinergic activity. So we give the patient anti-muscarinic anticholinergic drugs that include benztropine, and another famous drug is trihexyphenidyl. What is the side effect of pramipexole? What are the side effects of pramipexole? Is hallucination, gambling, postural hypotension. Right?